afternoon, all. Welcome back once again. So today we are going to have our 11th session of Foundation Course in Palliative Care, Season 3. And yes, today we'll be having a session on trauma-informed response. As we all know that trauma is deeply a very distressing or disturbing experience, and this will definitely manifest in different dimensions of a person's life, including the social, economic, physical realms. So yes, today we have a wonderful faculty here to deal with this session. Uh, I welcome Ms. Smriti Rana, who is a very trained integrative holistic psychological counselor, and she heads the policy, strategic partnership, and community engagement division at Pallium India. Ms. Smriti has led psychosocial training sessions at Pallium India since 2012 for medical and allied healthcare professionals, as well as for community members. She is the director of programs at Trivandrum Institute of Palliative Sciences. And it is indeed my great privilege to welcome you to this session, ma'am. Once again, welcome you. And over to you, ma'am.
Thank you. Thanks, Gayatri. Am I audible?
Yes, ma'am. Yes, ma'am.
Okay. All right. I can see that we have about 22 participants. I'm just wondering if everybody can just turn on their cameras for a few seconds so we can say hi to each other. And those of you who have been in my sessions before, I think know that, yeah. Oh, great. Nice to see everyone. Lovely. Okay, I don't know why everyone hides such nice bright faces. Okay, so I'm here to talk to you today, even though the session is titled Trauma-Informed Response. We will be going into it in a stepwise manner. And I know you've had some wonderful sessions with Joan Marston and with, sorry, one second, just check. Gayatri, if my network gets shaky, I'll log back in, okay? So no stress. So yeah, so we've had a few sessions with Joan and Atul, and I'm just going to sort of wrap up this particular thematic bucket, which is talking about trauma-informed responses to a humanitarian crisis. So even though it seems to us now that the worst is behind us, I personally believe that the long-term effects are things that we're going to have to deal with for some time to come. And trauma is not something that is experienced just for a short, acute period. It has long-lasting impact on not just the person who has experienced it, but also within their ecosystems and their families, because something like that is going to have a long-lasting and deep effect on the people that we interact with also. I will particularly be talking about trauma in the context of what healthcare providers and mental health providers and any care providers really have also experienced at this time. So if you have any questions, you're already familiar with how this whole thing works, please put it in the chat box, and from time to time, I'll pause to take up some of those questions, or we can have a much more, a deeper interaction at the end of the session also. So I'm just gonna start sharing my screen. Okay. All right. So what does it mean to have a trauma-informed response is that we need to be familiar with the idea of trauma when we respond to the issue or the crisis on hand, and that whatever it is that our responses are have to also be viewed through the lens of what trauma people have experienced and in what is the nature of that trauma, what is the intensity of that trauma also. So that's what we have titled today's session. But like I said, I'll be touching upon other aspects that have a direct impact on the experience as well. So familiar photos from 2018. And those of you who are based out of Kerala might have lived through some of this. We also have I think what stood out for me in these two photographs is the way the community has rallied around. So right from a clearly unwell person who is bedridden being carried through waist high water by well-wishers, neighbors, community members, and also somebody who's actually being transported in a little patram, two little girls. And so this was one um, aspect that that came through in these two pictures for me. As Joan and Atul have already pointed out, there are different kinds of crisis, humanitarian crisis. What we're seeing here is the earthquake in Nepal that also took place a few years ago, and it was a devastating earthquake, and devastating in the way that not only in the toll it took in terms of lives, but also in terms of how it affected the social fabric. These are just pictures from Kathmandu, and I'm Nepalese. I feel particular resonance with this. Entire areas were demolished. Ancient darbar squares were demolished. History was just erased. And this is only what we saw in Kathmandu. In the higher reaches, in the more difficult to access parts of Nepal, villages vanished. And we didn't really hear about those villages much. I know of families that waited for weeks for supplies to be airdropped. And there was a massive inequity in the way the evacuation and the rescue work also happened. There was a lot of disparity as to who was given access to what resources and stuff. So that's also something that we're going to touch upon later. We also saw scenes from the northeast of India a couple of years ago when Assam had a massive flood. And that is something that happens on a fairly regular basis in the northeast. And this is something that the people have had to contend with year after year after year. And again, the kind of exposure those stories get, or the kind of narrative that is spun around those stories, again, depends on who is affected, how much a part of mainstream media includes them, and so on and so forth. And again, you can see community members at work here. Pictures from not so long ago that all of us are very familiar with now. And this is where hospitals actually had infrastructure. But we also know what happened later in May, June, when we ran out of infrastructure, when we ran out of resources. And I'm not going to go into that at the moment. Another familiar theme of pictures. This might be triggering for some of you. I'm sorry if it is. If something in this entire presentation, I just really want to say up front, if anything in this entire presentation affects you in some way, then please reach out to me and we will talk. One of the offshoots of the pandemic was, of course, the migrant crisis that happened very early in our pandemic when we went into a hard lockdown last year. And to me, the picture of the man on the right was heartbreaking, as of course were the pictures of children and elderly people and all of those people who had to make their way across thousands of kilometers. And it was actually the largest internal refugee crisis a country has ever seen, in that sense, if you want to look at it like that. It was the largest displacement of people at a time that was already riddled with so much crisis that the disease itself brought on, the infection itself brought on. And so obviously all of these things lead to a sense of distress. And before we talk about trauma in particular, I want to take a moment to talk about what distress is. So in English, we call it distress, but what do we call it in other languages? What is distress? What is a word for distress in maybe the languages that some of you speak more comfortably or at home? Or so I'm going to ask for some of those words, and I'm accessing the chat box. So please feel free to type in. What are other words for distress in other languages, in other Indian languages? When we speak with other people about distress, what do we ask them? There are many words that we use in the English language that don't have direct translations into other languages. So I'm just wondering, what are the words we use to describe trauma, to describe distress? Question. what do we say in Hindi? Something for us to think about. And if you actually come up with words that, map to distress and trauma, then please write to us and tell us, because I think we need to build our own language when we talk to people about it. Tanav. Okay. Okay, so we'll keep building our collective vocabulary together. Now, what I'm showing you here is what we call a distress thermometer. Okay, and this is a commonly used tool to try and assess what distress looks like, what maladaptive behaviors emerge from dysregulation of our capacity to operate in a way that is healthy. Okay, so I want you to look at it from left to right, from green to red. Now, green is the zone where we are operating in a healthy, optimal manner. And typically, yes, we all experience some degree of normal mood fluctuations. All of us go through that in the course of the day. There might be a little bit of irritability, there might be a little bit of sadness. And when we watch something on the news or experience something, there might be some anger. When we hear something being said, or when we witness some sort of injustice or whatever else, things are part and parcel of our lives. We have a sense of humor about things. We are able to tap into a sense of humor. And for most part, we are in control mentally of our responses. Sleep patterns, again, some of us are just insomniacs by habit. Some of us sleep we're okay with 5 hours. Some of us need 8 hours. Some of us can love to catch a nap whenever we can. Hopefully not while this class is on, but that's the normal sort of, sleep patterns that we all have. And that's okay. Every now and then we have a disrupted night of sleep, but then for most part, we go back to some sort of a routine, even if the routine is not what the experts might consider ideal. Physically, we're okay. Our energy levels allow us to get through the day, and physically and socially, we remain active, and there's limited or no use of substance and alcohol and things like that. But as we start getting exposed more and more to these distressing stimuli, we might find that we get irritable and impatient. There's a little bit more nervousness. There's a little bit more anxiety. We're overwhelmingly big. Humor turns into some sort of displaced sarcasm. There's cynical humor rather than just good-natured humor. We tend to procrastinate our tasks. Okay, I'll just do this later. There might be some degree of forgetfulness. Sleeping gets affected. You find that, I have an ache here today that I didn't have earlier. I don't know where it's come from. Some tension in my neck. Some people might have nightmares, muscle tension, headaches, energy levels might go down. Don't really feel like catching up with friends. I just want to, be by myself. I don't want to talk to anybody. And if somebody feels like they need a drink to relax, they might feel that they need now 2 drinks instead of 1. But then we move into an area where it starts to get a little more unhealthy. And I'm not going to go through each of them one by one, but you can see what this is, right? Mood swings are much more volatile. There's more anger. At work, you might find that you just absolutely don't have the ability to perform even tasks that you used to be able to perform with ease. Or people might just start working even more. They don't want to go home, or they don't want to deal with other stuff. They use their work as an excuse to just escape some of the other emotions. Sleep patterns get completely disrupted. And I remember in the early part of the pandemic, I heard from so many people that they were having difficulty sleeping. Now, I wonder if any of you experienced that when the pandemic, when the first wave hit us, and then we didn't really know where we were, and suddenly people had to work from home and stuff. I wonder if some of you might have also felt your sleep patterns being disrupted. And of course, you can either go to extreme fatigue, or even there might be hyperactivity in some people, just a lot of nervous energy. And either you just don't want to interact with people much, or you have very, very few people left who you actually relate to. Most people you just don't relate to anymore. And of course, substance use and other such addictive habits also increase. And that might even be something, it doesn't even have to be alcohol or cigarettes or something more than that, it can also be something like what we call doom scrolling on Facebook. You might find that you're just constantly going back and just constantly scrolling through things like that on your smartphone. So all of those things are signs that there is a problem, and that the distress or the anxiety or the general exposure to uncomfortable stimuli has actually had a deep impact on you. So psychological distress, of course, manifests in various levels. It's not just psychological. Emotionally, you might feel all those things: stress, anxious, worried, sad, difficulty. And then, of course, there's a cognitive aspect also, which is difficulty paying attention, difficulty concentrating on a task, constant forgetfulness, so on and so forth. Physically, your body starts to respond the same way. And in terms of behavior also, more withdrawal, more, relationships become more conflicted. You might have more disagreements. There might be aggression. There might be, if there's a mismatch in communication with somebody, that gets even worse. And if somebody already has underlying issues like mental health problems or chronic health problems, diabetes, heart disease, all of those things, we find that those actually start getting a lot worse. And you might actually develop new comorbidities. So what I'm trying to say is that it's a 360-degree impact. Distress does not just cause us emotional pain, it also actually starts manifesting in a lot of different ways. And further down this program, we will be going into some of those mental health issues and some of those other issues in far more detail. But for now, I'm just sort of putting this out there. Very important to understand the red flags. If there is disorientation, confusion, very pronounced substance use on a regular basis, suicidal ideation, all of those things, those are very, very big red flags, and we absolutely need to get a professional involved at that point. This becomes out of the purview of just a social worker or a counselor or a well-meaning friend. This is where we actually need to tap into some of the more professional resources available to us, even those like helplines, if that's going to help, to talk to somebody who is actually trained in it. So these are some of the common manifestations. And there is a difference experienced when you're a caregiver under normal circumstances and when you're in a crisis. And what we've really seen in the pandemic especially is time. You're under a lot of pressure as far as time is concerned. And there is an urgency. And if you remember what it was like a few months ago, the sense of urgency was all pervasive. If you looked at your social media at that point, the calls for help, people trying to find adequate resources to meet people's needs, medicine, oxygen, an ambulance, a bed, all of those things. That sense of urgency was very, very, very high. And there was a lack of resources, which also added to the urgency, and disrupted communication channels also, right? How many of us wondered who is supposed to call? I mean, there were so many helpline numbers. There were so many, bits of information that were being put out there, but then we didn't really know, a lot of people didn't really know what was the appropriate channel, and also disrupted communication channels within caregiving circles themselves, because everybody's workload went up so much that what would have normally been a communication channel was no longer available, or it was very pressed for time, and therefore that communication also had to take place in a very, very, very short period of time. So you can't really get into some of the details that you would have otherwise gotten into. And so these were just some of the ways in which caregiving is different. But before I go to the next slide, I want to just stop for a moment and just elicit some responses from you. Some of you are caregivers, some of you are care providers in professional capacities. What changed for you when the crisis was at its peak? What changes did you experience in your ability to carry out your role? If you want, you can unmute and share, or if you want, you can just type it in the chat box. I can access the chat box as well. Is there anything on that slide that was missed out?
Hi, Smriti. This is Mudre from Mysore.
Yes, hi.
Yeah, when you were telling about this, I was just recollecting some of the things that were going on in my mind, particularly during the first wave. The kind of responsibility or accountability what we have towards our kids, particularly disabled kids. How I am going to protect her. That was the major thing. Even when I leave that, it's very, very difficult for me to imagine that thing. Now, we were seeing lots of deaths around. Schools are not running. The child is arrested at home. It has no place to go. And parents are really at a loss to understand how to cope with this situation. During the regular times, child would go to school in the morning 9:30, come back at 3:30. The child had somewhere else to go other than the house. That frustration really killed us. But there was no help available at the time. And of course, I do call myself as a very seasoned parent of a special child. Yet it was difficult for me, even after 30 years of managing a child, it was difficult for me to see that my child is not able to go out anywhere. I managed somehow to take her out in the car for about half an hour, something like that. But there was no physical activity at all. At that particular point of time, there was a very, very grim situation. How long this will go on? What happens to my child if I'm not there tomorrow? Who's going to take care? Though there are extended family and other things, it's perfectly all right, but everybody is apprehensive to come out of the house. Then it is nothing but surrender. You will have to ultimately surrender. Okay, whatever that goes on, it is going on. So there are 4 to 6% of parents like me who are suffering in this world. And whatever happens to those kids will also happen to my child. This could be too philosophical or a fait accompli kind of statement. But in reality, are we ready to face this? Structurally, are we ready? Do we have any kind of platform where we can seek help? Does the government has some kind of infrastructure in place to see this? Somebody calls these kind of parents and try to convince them or console them. There's no consolation at all. It did not happen. Wherever a particular institute where my child used to go there, I used to call those people and find out what they're doing. And nobody was aware of what the parents are doing, how they're coping with this very, very difficult situation. Things, see, during the second wave, by the time myself and my wife, we were vaccinated, it was not so, scary situation. And my daughter also has got the first vaccination now. She's waiting for the second during the August 2nd week, she'll be getting the second vaccination. But the fact remains that when we are troubled in mind, our susceptibility for infection also increases because our immunity level also comes down. How to hold ourselves to positioning ourselves to serve is to see that we keep fit in its totality, holistically, how we keep ourselves fit. Ultimately, we need to find out this, ways to comfort ourselves without having any dependency on the outside agencies when it is not available at all. It was so scarce. And probably I started calling people and finding out how they are managing. In that process, we got a kind of, solace. Okay, somebody is able to manage themselves. I want to believe that many parents have managed well. Even today, I'm not sure. We don't have any data about the disabled children, the children with cerebral palsy or muscular dystrophy or this, how they have managed. We don't have any data about it. This is what I wanted to share with you.
Thank you. I want to thank you very much for that perspective. And also for, well, having the courage to be vulnerable with us. Thank you. I think you've made many very profound observations. I don't think this is too philosophical. I think this is absolutely necessary, because really what was revealed was absolutely terrifying, and how ill-equipped, or how, even at the best of times, how ill-equipped we are. And this really sort of stripped away that layer of maybe false assurance also. And I think you've highlighted something for me today, which I'm going to make a note of what do we know of children and parents of children who've had to go through this experience. So one of the things that I also feel very, very strongly about is the fact that it comes down to a point where sometimes it's just crunched down into numbers and statistics, but behind every number and every statistic is a story which is so convoluted and so profound in its own right. And somehow, finding other people who are experiencing similar stories also is important in the vacuum that exists. So thank you very much. Thank you so much for sharing that with me. And I'm actually making note of a couple of things you just shared, because I feel like this is something that has been a blind spot for a lot of people, and we probably need to have a discussion about that as well. So thank you very much for that.
Thank you, Smriti.
Stuti, you wanted to say something? You want to unmute?
Yes. Hi, good afternoon, everybody. Picking up from what Sir just said, which he put forth very rightly, and I think I'm a mental health professional myself, and looking at the past 1.5 years, it's been about this shared vulnerability, a collective sense of vulnerability, because we found ourselves grappling with so much grief, with so much uncertainty as individuals, as a community at large. I remember that especially during the second wave, when we were attending to COVID patients and their families through online consults, there was really like a bottommost point that we touched as from the other side of the desk, because there was so much to take in. I mean, today you're talking to somebody, tomorrow or the day after you get to know that that person is no longer there. So that in itself is very distasteful and very distressing. So the point that I'm trying to make here is that more than anything else, the narratives of hope have undergone a tremendous change, because like I myself have struggled a great deal to kind of reinforce that whole idea of hope, of optimism, when you know that something is so bleak, something is so dark. So you have to go back to the basics. You have to reassess, whatever has been going on, and what is it that you can do, your little contributions that will matter. So that's about it. And I thought that it was sort of necessary to put it out there.
I couldn't agree with you more. It is absolutely necessary. And thank you for so articulately expressing that. I think what you just said is, it hits the nail on the head, really. Thank you, Stuti. And if anyone else would also like to share their experiences, please use the chat box. We'll come back to it further down the session. And what I'm also seeing in the chat box is apprehension, uncertainty, loss of livelihood because places shut down. So yes, it's a very, very different experience in a crisis versus a situation where we didn't have the kind of crisis of that scale. So now specifically coming to the providers, possible psychological syndromes that were experienced by healthcare providers. Okay, so there is a lot of information out there about the difficulties, the challenges, the practical challenges, all of that. And what are some of the psychological syndromes that healthcare providers operating in that crisis could possibly have gone through? Firstly, burnout. And this is something that we're still continuing to see. I think one of the hardest things right now to contend with is when we see, having very recently lived through such a horrible time, again, people going out there with no concern, thinking that it's over. The masks are off, the social distancing norms are all over the place and stuff. And what is really, really tragic there is that it's the same bunch of people who are still working with people's lives, who are still trying to save them, who are still working in the hospitals. What we're seeing in the US right now is a prime example of the pandemic of the unvaccinated. And there's a beautiful article that was written by a healthcare provider saying it's very hard for me today to conjure empathy for somebody like this person. because they were the same anti-vaxxers out there saying that nobody should get vaccinated. And now here is somebody who's on the verge of being intubated, asking me if I can get the vaccine now. So those kind of things, it's been cyclical for most people, but I think for the healthcare providers, it has been constant. And that is what is very, very difficult for a lot of people at the moment. So burnout is a syndrome that can definitely, I think right now, a lot of people are experiencing it. And actually it is characterized by loss in 3 domains: energy, compassion, and efficacy. And when you look at what this means, what do you lose in terms of energy? You're exhausted, both emotionally and physically. There's a sense of distancing from work and from people. You don't really, you don't have the energy. How many times have I heard people say, I just don't have the energy for that. I just don't have the energy for this. I don't have the energy to go out and have dinner with my friends after a long day. I don't have the energy for that Zoom call with my family. I've just come back from work. So there's a serious depletion in energy. There is a depletion in compassion, like I said. That's what's happening with a lot of care providers in situations that have gone through extremely high intensity, sort of constant caregiving requirements. And then what happens is when you lose your compassion for that time, there's a sense of apathy, there's cynicism, there's depersonalization. I can no longer, earlier my job used to be try and humanize every person I met, and I used to try and do that in the beginning. We used to say that, how do you communicate with somebody who is separated from their family during the COVID crisis? Ask that person, ask the caregiver, tell me something about your father that you would like me to know, which is a non-medical thing. So people were actually making the effort at that point to give themselves the vocabulary to humanize the whole process through those PPEs and those masks. And now it's like there's a sense of depersonalization, almost saying, how long are we going to do this? And excessively detached responses. You might find there's a lot of irritability also. I find myself getting irritated quite often when I see somebody being absolutely lax. Yeah, but it's okay. I've got my 2 jabs. What does it matter? So, there are lots of vulnerable people out there, even now, who are going to bear the brunt of people's, lack of, I would say, adherence or compliance with what is still required as safety measures. And I think that particularly hits the healthcare community very hard. There's also a drop in efficiency. And this is a classic sign of burnout, where all those tasks that you were earlier very enthusiastic about, you just do the bare minimum that is required. I know a lot of people who, including myself, who have a lot of things left on their desks that they're like, I'll just do it later. I'll do it later. And soon that pile is so high, but you can't muster the energy. So there's an interplay between efficiency, energy, compassion. So all of these kind of play into one another, and that drops your sense of accomplishment. Your judgment also gets a lot poorer. You start doubting your judgment. There are boundary violations, right? The ways in which you engaged with people changes. The language you use in engaging with people changes. And also, of course, there is a sense of low morale, and that is something that is a classic sign of burnout. And how do we recognize emotional exhaustion, not just in our colleagues, but also in ourselves? This is very, very important. These are questions to ask yourself. Do you dread walking into work? Do you hate the thought of handover and getting started when it's time for your shift? Have you noticed that you aren't motivated to work, or simply don't put the same amount of time and energy into things as you once did? These are questions to ask yourself, to think about when you think of your colleagues as well. And well, I'm not saying that everybody goes through this. Some people are motivated to be of service. But for a huge number of people, there is this drop, there is this depletion. And if you see any of these signs, it could very well be a sign of just emotional exhaustion. Now, I just want to take a second to take you through these 4 things, okay? There is a distinction to be made amongst these 4. Just while I let you read the slides, I'm sorry, Gayatri, I just need to, there's an emergency call. I just need to take it for a couple of seconds, yeah?
Okay, sure, ma'am.
Sorry about that. All right, so coming back to this slide, why am I showing you this? Because there is a distinction between grief, post-traumatic stress disorder, depression, and anxiety disorders. Okay, with grief, we often find that grief is confused with depression. They map very closely to one another in terms of, disengagement, in terms of sleep disruptions, appetite disruptions, and so on and so forth. So a lot of people end up mislabeling grief as depression. And we see that especially in, in palliative care settings a lot. And so we will be doing a much more in-depth session on grief, but this is just something for you to remember. And the emotional intensity of grief is very high, but over a period of time, people are able to re-engage and function. Okay, so there is that intense loss, that intense sense of pain and sadness, but over a period of time, people start re-engaging, they start functioning, and in grief, your self-esteem is not impaired, which is something that we see in depression. Okay. And what is PTSD? One of the hallmarks of post-traumatic stress disorder is a persistent and frightening thoughts, memories, panic attacks, a lot of substance use disorders, breakdown in relationships. You see this a lot in people with PTSD, and this is like a persistent thing. They constantly have flashbacks on that traumatic event. There's constantly all of those things happen. And with depression, the mood is depressed. There might be a sense of guilt. Anhedonia is the inability to experience pleasure. In grief, you still have the ability to experience pleasure, whether it is in a person's company. I mean, it might take a while after the immediate loss, but over time, you are able to experience pleasure. You're able to indulge in activities that give you some sort of joy, things like that. But in depression, there is complete anhedonia, and there is a sense of low self-worth. There's difficulties in sort of processing thoughts and stuff like that, which may not necessarily be the case with depression. And with anxiety disorders, there are different kinds of anxiety disorders. Those of you here who have studied psychology are already familiar with this. There are different kinds that manifest in different ways. So repetitive thoughts and obsessions, fear, panic, compulsive behaviors, all of those things are part of the anxiety disorder bucket. So I just wanted to sort of lay this out in front so that we don't start confusing any of these different aspects. Now, in a humanitarian crisis, there are some very unique stresses, which are slightly different from, which are very different from the kind of stressors we experience in daily life. And especially in the kind of, say whether an earthquake, a flood, pandemic, death and loss is, the volume of death and loss is much higher. And typically what has happened right through history, or at least in modern history, is that death is framed as a failure. If you look at our current healthcare system, it is seen as a failure of medical expertise. It's seen a failure. So even if you look at the language that surrounds death, it's like, lost the battle too. There's a war rhetoric that accompanies death. And typically, there's a very winning and losing kind of language that is used. So if you see, it's seen as a failure. And we also find that in humanitarian crisis, there are a lot of deaths that would not have occurred had this crisis not taken place. People who are young, people who are still relatively healthy, people who were in the wrong place at the wrong time, had a chance encounter with an infected person. So those kind of things, people who, so it comes across as unnecessary. This was an unnecessary loss. And the young people in the second wave, it's completely unnecessary. And had they been at an alternate location, time, situation, or with different resources, where if they were in a different country, maybe they wouldn't have died. So there is that as well. Personal safety becomes a problem in a humanitarian crisis. Lack of safety equipment, like PPEs, like important infrastructure that we need. And then also there is the exposure to the infection, the exposure to violence, stigma. How many healthcare workers experienced incredible amounts of stigma, even though they were the ones on the front lines. I know of so many stories where healthcare workers and their families were treated very badly by the neighborhood because they were convinced that these were the people who were going to bring the infection back home. So on one hand, you were relied upon to look after people, but on the other hand, you were stigmatized for it. And we know that a lot of doctors also experienced violence. And that is something that is also unique. And then there's, of course, if it's in the case of a humanitarian crisis like a flood or a landslide or an earthquake, there is the possibility of more natural disaster happening. There could be an aftershock of the earthquake. There could be more flooding. There could be a cloudburst where you are. So those are also unique stresses. Physical stress, sleep deprivation, exhaustion, disrupted food and nutrition intake. People who were wearing PPEs couldn't even use the toilet for hours on end. And just working in those conditions, in the heat, in cities like Bombay and any place that was hot in the height of summer, having to make critical decisions while being wrapped up in that outfit, it puts a lot of pressure on you. Moral and ethical distress, and this was a big one. Witnessing disparity, making hard choices, deciding who gets access to which resources when resources were scarce. Now, moral distress also occurs from a difference in the value system you hold and what you're being asked to do. And it may not be the fault of your establishment. It was just because decisions were being made, kept in mind the resources available. You may not personally agree with that, right? We also found that certain communities were discriminated against. I know for a fact where my family lives in Allahabad, in UP, I know a certain community of people were not even been given admission into hospitals. So watching that kind of disparity also leads to deep moral trauma and moral injury. Vicarious trauma through recognizing suffering. Vicarious is to live through somebody else's experience, and witnessing other people's losses over and over and over again also results in secondary trauma to you. So it's not necessary that you have gone through a loss, but witnessing somebody else's loss under very, very difficult circumstances will leave an impact on us. There is a sense of endlessness, which even I feel right now. Get ready for what's coming next. And like Mr. Ramakrishna said, when is this going to end? When are things going to go back? And actually, I don't even know what normal means anymore. When we say go back to normal, I don't really know what normal means anymore. So the sense of endlessness. Also witnessing morbidity, disfigurement, people having in other natural disasters and stuff, people who are trapped, people are being rescued, the injuries, the wounds, and of course, also just witnessing the sheer number of deaths, isolation, separation from families, and inability to share experiences with others. And this especially became true for a lot of healthcare workers. And I know in the early part of the pandemic, there were some doctors who hadn't seen their families in 7-8 months, who hadn't been there for the birth of a child, who couldn't be there with their elderly parents because of the risk. And so being separated, being isolated. And also, it's very difficult to share your experience, even as a mental health provider and stuff. There are issues of confidentiality. There are issues of, so many things that you can't really take home and share with a friend. And palliative care, I mean, this was a joke in my family for some time, where it's like, okay, when we're having a dinner time conversation, how was your day? What did you do today? And honestly, I'm not going to tell everybody what I did that day, because it was, we're supposed to share some good experiences from the day, and they might have been a good experience for me, but the lens is very different. So, oh God, you're going to talk about that child again, aren't you? And I'm like, yeah, but something really good happened with him. Like, okay, can we not talk about the sick, the child with terminal cancer at the dinner table? So it's very difficult, especially also in a crisis situation. And you're so exhausted. How do you even unpack this with somebody else? And maybe the only other people who can understand it are other healthcare providers, but they're going through their own trauma, right? So that is a problem. And there is a lack of officers had to function under rigorous protocols, following orders without question, differing values. Sometimes what a crisis reveals is that the person holding that post of leadership is not a competent leader, or is unable to adapt to the crisis in a way that also takes into consideration the emotional needs. Some people might place efficiency over well-being. Sometimes we're called upon to do that. Sometimes we find that the leadership itself is unable to grapple, is unable to make decisions. So those kind of issues also come up. And then, we're reporting to somebody, they're reporting to somebody, the country has a particular policy, the state has a policy that changes from time to time. The guidelines were changing every week, depending on the containment tools, depending on the trajectory of the infections and so on. Team-related stressors. A lot of people didn't know what their role was anymore because they had to do multiple roles, right? So even what were probably clearly defined roles and responsibilities in non-pandemic times became very blurred. A lot of places were operating at 50%, trying to maintain some sort of safety protocol. Okay, so we'll only have 50% on the field now, in the hospital now, then we'll rotate it. And so that 50% had to actually do 100% work. Existential suffering. And that is something that all of us, I think, at some level experience. Meaning, loss, meaning, purpose, hope. Those are the aspects of existential suffering. Trying to understand what this all means. Is this some sort of collective karma? Is this some sort of collective spiritual experience that we're supposed to learn something from? What are we supposed to learn? What are the lessons we're supposed to learn from this? So there's a lot of existential suffering as well, and challenges in measuring and reducing suffering. Nobody has mastered the art of measuring what suffering really is. And if you can't measure what is suffering, how do you measure the outcomes of your interventions? So unclear measures, inability to monitor and evaluate. And all you really got in terms of quantifiable data was number of deaths versus the quality of the death the person got, right? And that is something that in palliative care we try and aspire to at least achieving, even if we can't all agree on what those qualifying indicators are. But these are some of the unique stressors in a humanitarian crisis, and I'm going to try and move along a little bit faster. So now coming to the main crux of the session, which is trauma. What is trauma? So this is what trauma is. It results from exposure to non-normative, that means unnatural or abnormal experiences. It's exposure to this, which leads to a profoundly dysregulated nervous system. It actually has a physical impact on you. It creates a sense of extreme fear for varying periods of time, anxiety, all of that. And it disrupts your assumptive world. What is your assumptive world? Your assumptive world is, the maps you've created in your head all your life, from deriving from different experiences you've had, your formula for the way you look at the world, your cause and effect. If this happens, then this happens. Your plans, your logical thread that you pull through different experiences and so on. It gets shattered. So trauma is exposure to non-normative experiences that lead to dysregulated nervous system, that leads to also fear. And now all of this is interconnected. If you have a dysregulated nervous system, it affects your ability to think straight, it affects your health, it affects various other cognitive and emotional aspects of of the way you operate as well. And it's very hard to make sense of the world through that traumatic experience. So that's what trauma is, in a sense. It manifests as physical, cognitive, emotional, and existential. Like I said, it might manifest as acute anxiety in some people might actually just become numb, unable to feel anything. That is also, so trauma does not necessarily mean that you're sitting and like stressed out and crying and anxious and panicky and stuff. It could also be manifested as utter numbness. Very often increased substance use. Trauma, post-traumatic stress disorder is something that a lot of people here in this group might be familiar with. Demoralization, which all burnout and stuff, and loss of meaning. So these are just some aspects. I'm sure if you stare at this picture long enough, you can keep adding things to it on how it manifests. And what we need to remember is that if you have a traumatic response, to an abnormal situation, that is a normal response to that situation. Am I making sense? If the situation is abnormal and intensely abnormal, having a traumatic response is, in that context, a normal response. You cannot be expected to always respond with utter calm, zen, clear thinking, if you're being exposed to something that is deeply, deeply traumatic. So I don't know how many people can do that without a sense of detachment. So this is something that is increasingly being recognized world over, that we don't want, trauma is not something anyone should have to live with, but in that moment, it is not a pathological response. Just like grief is not a pathological response to loss, it is a natural response to loss. When you lose something you love, you grieve. Similarly, a traumatic response is a natural response to an abnormal situation if you're experiencing it. Now, there are some traumatic, specifically in the context of trauma, traumatic exposures within this pandemic as compared to other types of humanitarian crisis. So when I say other kinds of humanitarian crisis, natural disasters, accidents, tsunami, earthquake, all of that. So what is setting apart this particular pandemic from other humanitarian crises in your experience, in your sort of inference? Would anyone like to take a dig at this? What is different about the COVID-19 crisis and now the Delta plus crisis? Or what we've gone through in the last year. Okay, so I'm just going to move along. Please feel free to use the chat box. The unknown and uncertain nature of the virus. It is mutating. Every day we're learning about a new variant. Every day we're learning about a new, mutation. I don't know how many of us can even keep track of the different variations of it there are, how it manifests in people. Earlier they said not in children. Now they're saying now children. Earlier it was only older people. Now it's young people. In between there's news about some animals getting COVID. So all of those things, uncertainty and uncertain nature, which vaccine is affecting which variant of the virus, all of those things, lots of uncertainty. This has affected a global population. It has not been localized. So you can't even really get help from elsewhere, right? So suppose you have a natural disaster. If you had the earthquake in Nepal, there was humanitarian aid coming in from all over the world. So there were people who were able to respond because they were not affected by it. But in this case, the whole world was affected by it, and not just on a social level, but also on an economic level. Huge numbers of both those who are suffering with the illness and those dying from it. And of course, those who are watching all this happen. The contagiousness and the lethality of it. Okay, the virulence and the contagiousness of it. Lack of adequate protective gear leading to fears for one's own safety. I mean, that was a big problem in the early part of the pandemic because you really needed a very specific set of specific gear to protect yourself. And tremendous social inequities in access to care, not just within our communities, not just within our own country or in our between states, but worldwide. There are so many low middle income countries that don't even have the vaccine. The vaccines were first being hoarded by some countries. We ran, I mean, of course, there's also the whole how is medicine being used, who has what, all of those things. And access to care, supplies, tests, treatments, there was inequity on every front. There were some places that just didn't have the ability to test. What is happening in way rural, remote India as opposed to the cities? Yeah. So also it's, you have so much of it now digital. You need to get on this website, register yourself. How many people don't know how to use technology like that? What about all the elderly people living alone who don't have access to go to those places to get vaccinated? What about the people who are not educated, right? So there's a lot of that inequity. Moral and ethical conflicts regarding triaging and rationing of life-saving treatments, that's something we've already talked about. Conflicts within families regarding risks of COVID patients. And I'll tell you one particular cohort that really struggled with this were the nurses. Because let's not forget that the nurses are also, and I don't mean this with any, but it's a fact that the status of women in India, and I'm only going to speak for India, it's not only India, it happens in a lot of countries. The status of a woman in a family in India is very specific, so she might be a breadwinning, an earning member, but within the household, she has a certain role of being a daughter-in-law, of being a wife. And we know a lot of nurses had to make that choice at that point. Their sense of duty and service to go up and show up and be there versus having to deal with being the daughter-in-law of the house, where it was not looked upon with a lot of grace. So all of these different intersectionalities with gender, etc., also came into play. Conflicting information, planning, and guidance, big one. There's something called the psychology of a pandemic, which is really talks about how in order for anything to make sense, you have to have the 4 pillars aligning themselves: governance, media, law enforcement, and science. Science includes fraternity and doctors and scientists. Governance, media, scientists, and law enforcement have to speak the same language. And I'm going to let you reflect on whether that was the case or not. So when that does not align, crisis or any sort of pandemic like this, which has a lot of room for conspiracy theories. Sorry, Gayatri, just let me know if my internet is unstable. You can hear me okay?
Yes, ma'am.
All right. Yeah, so when you don't have these 4 pillars aligning, what happens is that in any such pandemic, you have the non-believers who think it's all the anti-vaxxers, the non-believers who all think it's a conspiracy, etc., etc., etc. You have those who are very, very paranoid. And then you have the ones in the middle who could go either way, or who say, okay, let's be responsible about it, But when you don't have this alignment between these 4, people will just take what they want from it. There's enough information to corroborate what the anti-vaxxers think, and there's enough information to corroborate what the paranoid people think. There is also enough information for those who want to be rational about it. People have their pick. So if you don't have a common messaging coming from these 4 institutions, so to speak, there is going to be confusion. And that is something that we need to remember as we go forward also. Who do you choose to listen to? Okay, now we've talked about the trauma. We've talked about all the difficult stuff. Connected to trauma is the idea of resilience. And very often we use this word in the context of children and, in the context of illness and things like that. But what is resilience really? It is the ability to respond to stress in an adaptive way. It is the ability to bounce back. And it is a measure of how quickly one is able to recover from adversity. Okay, so those are different ways of understanding the word resilience. Okay. Now, how do we deal with the amount of trauma that is unfolding around the world and is still, we're still not out of the woods yet with trauma. And a trauma-informed response to clinical distress is predicted upon certain fundamental principles that include, so trauma-informed response has some principles, yes? The first and foremost is helping the person find refuge or a place of inner safety. Now, things are going wrong all around you. It is impossible to find a sense of safety outside. It is important to help the person find some sort of sense of sanctuary, refuge, or inner safety. And there are a few very, very, very basic practices that you can incorporate for this. It's so basic that you might actually think that I'm joking, but I'm not. These are tried and tested, evidence-built practices that you can utilize. So I'm going to come to that in a minute, but please understand that a crisis is not the time for extensive debriefs. It is not the time to learn mindfulness. Because, and Isabel Paul, who's a mental health practitioner, is going to be talking to you about that in a few sessions from now. Well, we can debate this, but learning mindfulness, all of those things, and just saying be positive, you know, that what came up as toxic positivity, a crisis is not a time for these things, because it really doesn't help the person. And mindfulness and trying to be, you know, meditative and stuff, if somebody is depressed and going through trauma with a lot of very frightening inner visuals, sending them further inwards is really not going to help them. So very often you need to help them ground themselves in something that is less chaotic at the moment. Their mind may not be the place for them to go to. So what do? There are these 4 resiliency practices, and you'll find these resiliency practices also in the field manual of palliative care, humanitarian crisis. Some of these things, okay? A moment of self-compassion. And this is, I know it sounds very, very surface level, but it is very important for us to remind ourselves and the people around us that they are doing their best in this situation with the stuff that they have access to at this point, with the resources available to them, with what they have control over. They are doing their best. And it's a fact. Most people are doing their best in that time. No one in a crisis is going to say, hey, I have a better option, but, you know, I'm feeling too lazy, so I'm just going to do this. Most people are doing their best. Grounding, taking a few moments to notice your physical, and this is back then going into your mind for some people who are experiencing a lot of turbulence. Scanning your body slowly, head to toe. Where is your tension? Releasing that tension without judgment. And a very powerful experience we have found, and I can tell you that there are some of us who've been meeting across 6 continents every Friday for healthcare providers. Very, very powerful exercise is to just feel your feet on the ground. It has a remarkable ability to anchor you. And I would even say that if you have access to a little patch of grass, take your shoes off and stand bare feet there. Practicing the pause. Now, what is it to practice the pause? It's to just stop. Just stop. Right now, I'm going to ask you all to just stop. Stop thinking. Stop trying to process the information that I just gave you. Just stop and take one deep breath. And I'm actually going to ask you to put your feet on the ground right now, squarely. If you can take your shoes off and do it, do it. You can do this for a minute, you can do this for 5. So that pause is actually a very, very good thing. Now, it's kind of easier to do it in this Zoom setting, in this classroom, where we're just here. We've set this 1.5 hours aside. Try doing this when you're actually stressed out. I really hope my presentation is not stressing you out, but do it in the middle of a crisis. If you have a car breakdown in the middle of the highway, if you're, in the middle of a really uncomfortable situation, do this, practice the pause. You'll find that it really helps. And attention management. So this was a beautiful piece of advice that I was also given, and this is a part of resiliency practice, is people always worry about time management, no? God, time management is so bad. Time management is so bad. Try practicing attention management. And if you manage your attention more than you try to manage your time management gets better. Now, if a task requires 10% of your attention, give it 10% of your attention. No more. And yes, some people might say this is very different from mindfulness. No, there are things that you be mindful of your, your nutrition, mindful of eating, mindful of breathing, all of those things. But In terms of what you give your attention to, your attention is the biggest, most precious thing you can give anything. Choose wisely what you want to give your attention to. And in a crisis situation, what really helps is to shift, just with intent, shift your attention to something very, very normal, like a cup of tea that has no value or emotional attachment to it, to a tree outside your window, to a plant that might be sitting on your veranda, something that is not emotionally charged. Shift your focus on that. Try and just look at it, absorb it with your entire sensorium. What does it look like? What is its color? What are you smelling while you're looking at it? Just your 5 senses, and then come back to what you're doing. And it actually helps. Okay, so these are just 4 resiliency practices. If you look them up, you'll find there's a lot of literature on them. And I can tell you from personal experience, this has helped me and a lot of people that we've worked with as well. Resiliency practices in a larger setting for providers, very brief debriefing sessions, which just allow you to dissect one particular thing that happened. Okay, now just to recognize, how did that go for you? Yeah, it made you feel sad. Yeah, it made me feel sad too. Oh, I felt guilty. What exactly did you feel guilty about? No, I think I should have done something differently. No, I think you did your best under the circumstances. Yeah, I felt it too. And not one long debrief of the patient's entire history and everything. No, not that. Acknowledging emotional response. Name the emotion. I'm angry. It's okay to be angry. It's fine. I'm really sad right now. I feel very demotivated. Name it. Short mindful practices like the ones I just took you through, and self-compassion, which is honestly, it's such a simple phrase, very, very difficult to do. Very, very hard to practice self-compassion. And as a team, open, respectful communication, inclusivity. It's okay for people to have differing experiences and differing perspectives on the same experience. Modern Krishna did for us today, like Stuti did for us today. It's very important for us. If we want other people to be able to open up, we should be able to do it ourselves. And I think vulnerability is the soul sister of resilience. You can't keep it all in and then be resilient. It has to also find expression somewhere. Affirm, talk about what has happened that went well. Very often we talk about the problems. We very rarely talk about the accomplishments and what went right, even if it's a small thing. Hey, we caught that in time. Hey, you know, I was able to do this, which probably prevented something from escalating. Small things. And appreciate individuals. A culture of appreciation is very, very important in a time of crisis. Okay, so find things to be grateful for, not just in yourself, but in your team members as well. And once the crisis is over, whenever that is, whenever the acute crisis is over, whenever the larger crisis is over, it is very important to recognize and process grief in our colleagues, in our friends, in our families. Encourage reflective practices. Storytelling is very, very powerful. Find storytelling circles, find those podcasts that help you with that. Creative expression, writing, and facilitate post-traumatic growth, which is share experiences. Sharing experiences is very, very important. And this is what I mean by getting behind the stories, getting to the stories behind the statistics. It's very important. And maybe there is a need for a systemic overhaul. There's so much all of us have learned. We can't change the system at a national or international level, but perhaps we can bring about some changes in our own communities. As we have a bit of a breather between waves, perhaps we can use this time to build resilience within our own communities and also to make people aware of trauma, of grief, of these things that are really going to impact us in the long run. Link them to resources that they might need. Pallium India, along with 3 other organizations, we run a emotional distress helpline. Those are things that also help. And maybe generating some sort of, confidence in people to use these non-traditional ways of accessing help. India is not a country that had the culture of picking up a helpline to talk about their problems. Well, we didn't even really have the culture of mental health interventions. But now there is this, it's a sharp focus on this. So educate your community about it as well. And I think for all of you, it's, this is very important for us. We have a moral obligation to ensure that we are not sacrificing our own at the altar of caring for others in great need. I often hear people talking about self-care and how important it is. But when we ask someone to look after themselves or to find a space for self-care, I find that sometimes it's absolving us of our responsibility of making it possible for them. As people who run organizations or work in organizations, don't just talk to your colleagues and employees about practicing self-care. Give them the space to do it. You know, I hope you're looking after yourself. That nurse who comes to work at 8 in the morning after making her, entire family breakfast, after making sure there's something for lunch, after making sure the child has been, the computer is working for, or the smartphone is working for the child to attend class, comes and takes care of how many other people in the hospital, goes back and has to again make dinner, has to get ready, has to review the child's homework. She does not have time for self-care. So maybe we need to create that space for her. And please remember that you cannot pour from an empty cup. So no matter how strong our resilience or however, let's not wait till we're depleted. Let's keep ourselves replenished at all times. And finally, I just want to end on a positive. The evidence for healing post-trauma exposure is that anywhere from half to 3/4 of trauma survivors exhibit what is called post-traumatic growth. And it is important to know that most of us can find meaning and grow through the often painful, powerful, and profound experiences of humanitarian crisis. So that's what the evidence indicates, that half or 3/4 of us can actually experience growth from this experience. So I'm going to stop with this, and I am happy to take questions. Let me just. Sindhu, your question is about institution governance. Governance is our government. And the policies, the protocols, if your government is telling you this is what you need to do in order to be safe, and this is the vaccine that's out there, etc. But if the media is saying something else, the law enforcement is doing their own thing. Scientists are actually not agreeing with what the government is saying. That kind of dissonance causes confusion, which leads to further disruption, right? So does that make sense? Okay.
No, I just missed. I couldn't get you. Your voice was not clear then.
Oh, sorry. Okay, yeah. So law enforcement, science, governance, and media have to align. Yes, resilience is about activating parasympathetic arm of the autonomous nervous system. Absolutely. So we have some time. We have about 15 minutes. Please feel free to turn on your cameras, turn off your mute settings. Questions, comments, reflections, reactions, everything is welcome.
Smriti, this is Mudra again. When you're talking about resilience, my take is that particularly it is also true for the term what we're using for burnout. How do we avoid burnout? How do we show our resilience? It all depends on every day. Why do I come to my palliative care center? Why do I come to my workplace? If that commitment, if that reason is very, very strong, it is possible to maintain your resilience as well as to postpone your burnout. Considering the physicalities, it has got certain limitations. Burnout cannot be stopped at all, but it can develop, the replenishment can happen better when we look at our own decision-making process. Because we are all we face the consequences of our own decisions. It can be very simple example I would like to tell you was, a child comes into this world with the consensus of husband and wife. And whatever the child undergoes in this world, parents are responsible. In that decision-making process, the child has no role to play. It is always one-way traffic. If that kind of commitment is shown to in the workplace, probably we'll be able to show better efficiency as well as better accountability, better responsibility, and the burnout can be managed better when we answer ourselves why we are coming every day to the workplace. It has got physical limitations. I'm not denying that, but it is possible to renew our energies when you keep on answering this particular question more often. We may become very mechanical in doing our work. Rather than being mechanical, let us give a purpose for that. Let us remember why we entered the institution to work. So that gives a better meaning for working on day-to-day basis. That gives the better compassion level. You were telling that compassion also it will be depleting. Definitely it will be depleting when there is a very bitter expenses continuing. Definitely it's very difficult to maintain. But as you said, pause, feel about yourself, where your cheek is, where your nose is, where your eyes are, and think about yourself, why you are undergoing all this ordeal. It is because of your decision. I also feel when the kind of the way you have been working, I'm very much sure you keep answering yourselves why you are doing this. Otherwise, it's going to be very difficult. This tenaciously working for this kind of purpose, I don't think it's very humanly impossible if you do not have a proper mindset for that. If you don't position yourself to serve. Every day I come to palliative care center to help a fellow human being. That is why I come to the palliative care center. Probably when you talked about resilience, this is how we should respond when we start feeling the burnout or feeling the fatigue. It is very true for all parents. They still, despite having the sleepless night, next day they go to the office, next day they work. The whole day they work and they come back. They may not be able to sleep again during the night because the child is suffering. It is balancing with your emotions and the kind of accountability you have in the workplace. It is a kind of positioning yourself. Again, I come back to that word positioning. Constantly I work on that. My experience with my banking industry or with my child, it is always the accountability. I decided to enter the bank to work for 32 years. I decided to get my child into this world. Now she is 31 years. There is no respite from that. But when you start looking at the accountability, the commitment, it is possible to maintain our positions and discharge our responsibilities better. And when it is supported by affection, it's all the more better.
Thank you. Thank you very much. Yes, I agree. And I think that's where when you talk about how trauma is experienced, we have that little globe that talks about existential trauma and spiritual trauma. And that is the domain of meaning and purpose, which is something that you have talked about. Accountability, finding, why do I wake up in the morning and why is this important to me? This is what connects you to your work. This is the meaning you derive from it. Now, the problem arises when that is challenged.
Correct.
And so that interplay of physical, emotional, mental, and spiritual, I cannot underline enough how important that spiritual domain is. And by spirituality, I don't mean only religious beliefs. That is only a part of it. People are connected to what they do, their roles, who they are, etc. All of those aspects are very, very, I would say, core to the experience of whether it's trauma, whether it's crisis, whether it's of a high functioning individual, somebody who's able to wake up every morning and show up at work and stuff. So that aspect of why am I doing what I do? What is it for? The tenacity that arises from it. So I think there's an interplay of all these different domains, and I might have that in droves. But if my body is unable to keep up, then that's not going to help me very, very much, yes. Right? Satish, thank you very much for that suggestion. I think I would love to bring in the science of stress management and the autonomic nervous system, but we have deliberately kept these sessions very broad stroke, and we haven't gotten into the clinical, not clinical, but even like, I mean, I understand what your ask is, and perhaps we'll try and incorporate it in a way, because we usually for the FCPC sessions, we have a very vast a bunch of people from various backgrounds. So we try to keep it to points that are easily understood by everybody. So the autonomic nervous system would get a little bit technical, but let me see how I can try and bring it in the next time. Thanks though. Any other comments, any other reflections?
I particularly liked, Smriti, when you said we need to create self-care spaces. It's so easy to say, take care of yourself, and at the workspace, whether it's a room where it's just a quiet room where one just goes and stays there, or this is very important. And then the onus is, the space is there and people can access this space, and whatever it is, scream, shout, cry in that space, but this is very important.
Yeah.
And
I agree. And I sometimes there might be so much going on at home that home is not the place where you can get that. You might have a toddler who doesn't let you go to the toilet for 5 minutes, right? So what can we do in our workspace where we have, like you said, a safe room where somebody, if there's really starting to, burn out, maybe just go in there for half an hour and be by yourself and no one's going to bother you. Maybe that's the kind of space we have to create. You're absolutely right. I think that's a very practical idea also.
Yeah, as employers, I think, it's no more just the salary, take home and go. We have to create these spaces. It has to be inclusive of everyone, from our the workers who come to clean, to cook. And yes, I can understand the cognition of somebody saying, yes, I wake up to go and serve people, but this is not possible for, say, the man who picks up my trash. Why is he working? He just has to feed his family. How can I ask him this question? So how do we include their burnout?
Very important question. Very, very important question. And thank you for answering that. I think that is something that also in the pandemic, we realized that the people who are taking out the biohazard waste, the people who are cleaning up all the medical garbage, the people who are handling the discarded PPEs. I mean, what happens to all those folks also? Yeah.
Thank you for Smriti, this is Mudra again. I would like to reinforce what Ms. Sindhu was talking about, the sense of inclusiveness. See, when we look at ourselves, how our life became comfortable, we always speak few people, like my parents or my friends or my teachers, something like that. We never look about people who come and clean the clogged sanitary pipes when it is clogged.
Yeah.
We never look at people who are delivering the newspaper at my residence, the boy who delivers the milk packet at my residence, or the person who was taking care of my cycle when I was going to college, or that wonderful moment when I came out of my mother's womb, the nurse who brought me out safely. We never include these people in our lives. But unfortunately, that segment suffers a lot when they are hit. Probably the kind of acknowledgement we make, it is not rightly placed. The luxuries what we're enjoying today, it is not properly acknowledged. It's extremely difficult for those people to ask them to be resilient. It is unfair.
So that brings me back to how we started the session, and I'm going to please request your cameras on. So we have about 6 minutes, and I think this is a great segue, Mr. Ramakrishna, to come back to the first part. We amongst this did not have enough words to name trauma and resilience and distress. So is trauma-informed response only for people who understand what the word trauma means? What is the word for trauma in your mother tongue? What is the word for resilience in your mother tongue? How do we include people in these conversations if we don't have the language to talk to them about it. Does the guy who does the manual scavenging know what the word trauma means or what resilience means? And then how do we operationalize that for somebody like that? So I think there's something very important here that this group has struck upon. It's not just the theory, it's not just the framework, it's the language in our day-to-day interactions. How do we address these issues if we don't have the words for it outside the English language? When you go and speak with your team or people you work with, how are you going to broach the subject of compassion? Okay, karuna, we know that word. We have words for that. What is the word for resilience, guys? In any other language? I'd really like to learn. So how do we do this? How do we do the resilience practices? How do we do the safe rooms? How do we, there's no one size fits all. So I'm not suggesting that for a moment. Okay, so this is where creativity and innovation also have space. And I think it's really upon us. When I said, is it time for a systemic overhaul? The systemic overhaul comes in small incremental pieces. And I really believe that it's actually the power of the community that can bring about that change. Why did Kerala get the first ever state level palliative care policy in a developing country? It's because the community demanded it. And the government had to then recognize it. Kerala has undergone its second revision, 2019, when most states in India haven't even had their first draft. Again, it's because the community recognizes that this is what they need. And people come together from different parts. There are the beneficiaries, there are the advocates, there is the civil society, and then we speak the same language and we demand that this comes to us, right? So it's a groundswell that really builds it. So I'm glad that we're going to be ending on this note. Last couple of minutes, I'm going to invite more people to. I hope you're making a note of this chat box, and I think we need to start a little dictionary of FCPC where we start putting down these words, because I think these are very important words. So let's start that as wine for all. FCPC session, we need to expand our vocabulary a little bit. Okay, so last few comments, if I may invite, and then we will close this session in 2 minutes. Mr. Mohan Kumar, is that the word for resilience?
Yes, ma'am.
Wow. Can you say it out loud for me, please, once?
Sthiti Stapakatva.
Thank you. Okay, so if there's nothing more that people have to share, please make sure that you fill in the feedback form. Happy to take the suggestions. Thank you, Satish, for that. Any more suggestions, please do write in. And if for any of you, like I said in the beginning, if for any of you this session was particularly triggering, please write to me. It's smriti@palliumindia.org, and I hope you'll take care of yourselves and you are given the space to care for yourself. So I will see you soon. Please take care, be safe.
Thank you.
Thank you very much.
Thank you,
Thanks,
ma'am.
guys.
Thank you so much for that powerful presentation. Thank you.
Thank you.